Well, people are logging in pretty quickly, and so I think we can go ahead and get started. Welcome. I'm Andrea Baer with USAID PRH in Washington, and along with Judy Maboya from FHM Engage and Elizabeth Pena from FHM Engage, we're delighted to welcome you. This, of course, session is focused on Kenya for the Healthy Markets Community Practice, and it is a continuation of late last year when we had a session on Kenya, but we're not able to include all the speakers, and so we're really delighted for everyone who's joining today, and we'll continue the Kenya conversation. So happy to have that. Also, if you didn't hear me mention it before, we have a Mentimeter up in the top right there that you can scan the QR code. There's just a handful of questions. We're probably not going to share the results today, but they're part of a slightly larger survey that we're using to get input and ideas for consideration as we continue, as FHM Engage continues to plan out this coming year. And I, along with Ben Light from UNFPA, have the privilege of representing the co-sponsor organizations, USAID and UNFPA, for this Healthy Markets Community Practice focused on family planning and taking, for the most part, up until now, a country focus each month. And I can clearly say we're going to continue that, but we do want to also hear from audience and participants about ideas, both for countries and also specific topics of interest. And the call is being recorded because it will be shared on the Health Market Links website. And with that, I will pass it over to, I think, our colleague. Well, first of all, I'm going to show you the agenda. Thank you, Elizabeth. So you can see that we're going to start off by actually really happy to have one of our colleagues from USAID Kenya who's going to make a few remarks, and then she'll pass it on to Judy, who will just do a very brief recap and refresh from some of the earlier Kenya organizations. And then we have a nice lineup of people there. And what you'll see is that, as in prior calls, we're going to ask each of the speakers to be pretty brief, so kind of 8 minutes roughly, so that there's time for discussion. We know everybody could probably talk for a full 40 minutes, so we appreciate this way to generate discussion. And with that, over to you, Jane, and welcome.
Thank you. I'm checking if you can hear me.
Yes, we can hear you.
Okay. Thank you very much. Happy to be in this meeting and excited that we're having this session that is focused in Kenya. Let me just put on my camera a bit. I'm just going to, sorry, it is not very clear, but I can see my photo there. I'm not sure where that came from, but yes. So as you said, Kenya and East Africa, we are very excited to be working at such a time like now. We have worked to develop a private sector engagement policy that aligns with the USAID PSC, a private sector engagement strategy that aligns with the global USAID policy. And we are pursuing value partnership with the different private sector players across the value chain, right from manufacturing, local manufacturing, to service delivery, to increase or rather improve outcomes. And we are working to identify and to work more closely with entities that have market shaping solutions that will see the private sector incrementally play a leading role in health areas that have been traditionally public, for example, HIV and AIDS, malaria, TB, but also leverage on the private sector expertise, their technology, their solutions. And we have 5 focus areas. I'm just going to mention them, one of which is local manufacturing. I've spoken to that. This follows the learning from COVID, and that we need to bring production near consumption. So we are working more closely with government and stakeholders, manufacturers, to see how to create or enhance a more enabling environment. The other one is optimize private sector capacity and expertise to expand coverage and quality. And the other one is access to finance and strengthening government oversight and engagement with the private sector. So these are the key focus areas that we are working around, and we have different partners, including FHM, who are working around these initiatives. So happy to join these conversations, and over to you. Over to you. Back to you, Andrea.
Wonderful. Thanks, Jane. That was really a great way to set the stage. So I really appreciate that. And I think our first speaker, as I mentioned, will be Judy Maboya from FHM Engage. Judy, over to you.
Hello, everyone. I'm hoping you can hear me. Let me know at any time if I'm inaudible. Thank you again for attending this session as part of the team that supports the planning for this Healthy Markets Community of Practice webinar. This session is focused on Kenya, and it is a follow-on from the one we had last October, from which I'd like to provide a few highlights from that discussion that would also help in responding to some of our questions in the polls that we will put out today. So from our last session, we took some time to take a look at an overview of the trends in Kenya's family planning private sector market. We also heard from innovators who are changing how health products and services are delivered. We heard from partners working in health finance. And lastly, we heard from partners who are working to improve contraceptive commodity availability. What we did see is that in trends in family planning, we saw an overall decline in total fertility, while at the same time seeing a decline in modern contraceptive uptake amongst urban women. So while rural women, there was an increase in uptake, urban women, there was a decline in uptake. So data from Kenya's Demographic Health Survey showed a significant increase in implant use while a decline in injectable use. We also saw that a lot of private sector products, what is available through the private sector is really the short-term methods. And there's an opportunity to improve the availability of the long-term methods. And lastly, when it came to the overview and the overall trends in the family planning private sector market, some of the key constraints that were identified were challenges around demand generation, information on what is happening in the private sector, regulation governing the availability of commodity cross-sectorally, and financing challenges, especially with commodity financing in the next few years. When it comes to innovation in the delivery of health products and services, we heard from two partners. We heard from MyDawa and from Kasha Technologies. MyDawa is an end-to-end e-health, telehealth and e-pharmacy platform. And Kasha is a last-mile distribution platform that provides both pharmaceutical and consumer health products. What we were able to see from these particular platforms was that technology can be leveraged to improve health outcomes by shortening supply chains and working with suppliers directly to improve affordability, by providing patient-centered care. When patients can interact directly, either with the provider, they can order a lab test, and they can have the medicines delivered to the comfort of their homes, schools, or workplaces. Technology can be used to provide reliable health information to both users and health providers. It can be used to provide quality products that reach the last mile through both online and physical stores, and to also offer referral services to health facilities. When it came to health financing, we had Afya Research and ThinkWell. Afya Research presented on their work, which was called the Ubuntu Afya model. Their work centers on partnerships with communities. And this model came about because rural communities aren't always prioritized for private healthcare enterprise. So AFIA research's work on the Ubuntu model was centered around operating medical, a medical provider operating financial services as well, so that the revenue from the supplementary enterprise can subsidize the cost of running providing the medical services. AFIA research demonstrated their work was primarily in family planning, working in counties with high teenage pregnancy, targeting adolescents and young women. And their kiosks were able to, they achieved a 42% increase in family planning uptake in the counties in which they work between 2022 and 2023. And it was, I think that was demonstrating the outsized impact of working with local communities. We also heard from ThinkWell, which is a health systems organization that tailors health financing approaches for UHC. They presented their work on family planning financing for the private sector. ThinkWell spoke of their work in changing provider methods at both national and subnational levels, including modalities such as fee for service through the Social Health Authority, and including family planning within the essential health package for the private sector in primary healthcare communities. This work would incentivize private sector providers to take up long-acting and reversible methods, which are currently not widely available through the private sector. Which will also mean that wealthier women who currently must use the public sector would then go to the private sector and lowering the burden on public facilities to provide those methods. Lastly, I think the last theme that really emerged from our last session was around contraceptive commodity availability. We heard from Jacaranda work on the roadmap for private sector provision of contraceptive implants. Jacaranda identified a number of priorities to sustainably increase the delivery of implants through the private sector, including building a private sector supply chain for contraceptive implants, which currently is not well put in place. Measures to offset the anticipated cost in increase of the commodity once public sector provision is withdrawn. Improving labor capacity and motivation for providers to be able to offer this method. And in conclusion, we had from commercial sector players who are also improving and provide these commodities within the private sector. We heard from DKT Health, who were able to share their work on building brands for contraceptive commodities in Kenya. And we also had a partnership between Zuri Health, who is a telehealth services provider, working with Bayer Healthcare, who are a manufacturer, to increase access to information on modern contraception through a mix of online and offline interventions. So we had a really robust discussion, and I'm looking forward to today's discussion. Over to you, Andrea.
Thanks, Judy. And for those of you who are interested, we'll put a link in the chat to the slide deck that supported all those speakers that Judy was highlighting. So just as I bring Nancy on screen from Girl Effect and invite her to start, I also want to mention that after we hear from the speakers who are scheduled, if there are any other local partners or activities in Kenya who want to just raise their hand and share anything, we want to be informal in that way as well. So so know that you can mention something at the end if you're not on the schedule. Nancy, over to you. Let's learn about Girl Effect.
Thank you so much. Good afternoon, good morning, everyone. I'll take you through our work as Girl Effect in Kenya. Next slide, please. So who's Girl Effect? So Girl Effect is an SBCC organization arming adolescent girls and young women with the tools they need to address their concerns around health, ranging from SRH to HIV to menstrual health, and also looking at livelihoods. So we use a lot of content. We put a lot of effort on working on content that appeals to the girls and really the young people, from chatbots to chat shows to drama TVs to tech that directly talk to girls. We are creating safe spaces and sharing facts and answering questions in a fun and truthful manner about health, nutrition, education, relationships, and so much more. Yeah. Beyond the girl, we also appreciate it's not just a girl problem. So we target the girl, but we know by targeting the girl, we reach those around her, hence the girl effect. So these are some of our brands we have across some of our implementing countries. And for Kenya, I'll focus on Wazi. So on Wazi, this is a partnership we had with MSD to understand and identify the key barriers and enablers for girls 15 to 24 on contraceptive uptake. We also were working on co-creating with the young people a minimum viable product, which we are calling the MVP, for adolescent girls on SRH needs. And then in collaboration with key stakeholders, establish a functional, efficient, scalable ecosystem to support girls aged 15 to 19 to access contraceptives. So this is work in progress, and we'll be sharing where we are to date. Next slide. So Wazi coming to life. So this is what it is in a nutshell. And there's so much more that went into this 1 year of implementation. We took a bit of time, like almost 6 months of 2023, just coming up with a product. That took a bit of time. And then we had around 4 months of implementation. So Wazi is sort of in 3 phases, is divided into 3 phases. So we're looking at the awareness stage that is really coming in from design sprints that we did with the young people, talking to the experts, the community in the different sector, public, private, to get insights in terms of how this MVP or minimum viable product can look like, can be like. But of course, just centering it on the girl, what does she need? And so one of the insights we got from that process is that she would want a one-stop solution, like one-stop solution. So this is what our MVP is around. And so to facilitate that one-stop solution, we had a strategy around increasing awareness about that MVP, which is what we're calling Wazi. So we had 2 main categories, looking at hi-fi girls, like girls who have access to digital. We know 60% of our girls have access to digital, be it feature phone or smartphones, they do have access. So we had hi-fi. So in hi-fi, we had a lot of content around YouTube. We developed podcasts. We had influencers talking about Wazi. We also had serialized short dramas to boost the conversations and drive traffic to Wazi, the chatbot. And then the equivalent for the lo-fi, the girls who are marginally not digitally divided, we did have a solution around a USSD platform. And so for this, in terms of awareness, we were big on radio. We also had a concept we called Wazidada. So Wazidada is built from this insight around having a big sister who you can go to for information and advice when it comes to SRH. And so that in an entirety was driving traffic to engage with the chatbot and the USSD platform. And then from here, we had a bit of content going on. We had worked on content where the girls would engage on a lot more on SRH, on menstrual health. There was also a bit more on just sex education broadly, just in a fun and honest way. And then from there, we also were linking girls who needed to take up service to a service provider. So we had this insight around a concierge role. Remember from the insights we did at the insight gathering, girls did tell us that they want a one-stop shop. So we wanted, when girls interact with this platform, that they can get end-to-end support. You can get support on demand, and you can finally be linked to somebody else who support even further that which you have concerns over or are in need of. So we did partner with some of them, some of the some partners in Kenya for that initial phase that include Kasha for their products especially, and Jacaranda Health also for their service delivery. We also did partner with Sugarize for their service delivery also. And so that was the consumer journey for the girl from beginning to end. But I think what just to mention is that the concierge role then would allow us to build on additional partners so that we have a one-stop solution for girls digitally, which is also something that can be sometimes be conflicting for girls out there in the community. Next slide, please. So what happens in the last 4 months of last year? So we did all this awareness. We reached many girls, in millions actually, but we're very keen on engaged reach. Like how many of the girls are we talking to or are seeing our messages out there, are able to come back and like and comment and share on our work. So we're really tracking on engaged reach. We think that's a good indicator of, just going beyond seeing our messages to actually interacting with our content. And then beyond interacting with our content at low-fi or hi-fi, are you able to get into a WASI or the product, what we're calling the product reach? So we got around 42,000 looking at the bots, giving us around 42 and USSD 10,000, so an average of 42. We did have instances where we'd have a girl on both sides of the USSD and also the chatbot. And then from that one, we were also able to refer to those girls who are in need, linking those to services. So for this one, especially towards the tail end of the initial phase of the project, we worked very closely with Jacaranda Health, who we are calling human in the loop in terms of that continuum to take girls through additional counseling around FP. Next slide.
And
right.
Nancy, just to say 2 minutes to finish. Okay. Thank you.
I think I have 2 slides. All right.
Okay.
Thanks so much. All right. And then so we did have a couple of, we had an entire research agenda. So I'll just pick a bit of the highlights that talk to some of our objectives around shifting knowledge. So we saw a shift in pregnancy. We did an online study around with 250 young women. And so we saw a shift in knowledge in terms of, knowing when they can get pregnant. That's up to 12%. When it comes to contraception, we saw a decrease by 13% at endline in terms of confidence to use contraceptive. That in itself increasing by 5%. Then there was an issue around preference for male condoms, that increasing by 7%, and intent to use a female condom by 4%. That's intent. That's a very interesting insight there. And then on STIs, we also saw 5% increase in number of girls who could correctly describe what STIs were. And then when it comes to dual protection, it wasn't well understood at the beginning, but we saw this coming from 37% to up to 63%. So just showing those knowledge shifts through the communication of girls who are actually going through the chat, the journey, not the who are going through the chatbot, the WASI chatbot. Yeah. Next slide, please. Then there was also, we had a question, we had many questions, but we also thought this was interesting for this forum. Significant increase in those expecting positive experience using telemedicine in the online community, because then our solution is also largely digital based, one-stop shop solution. There was increase in terms of positive experience and that intent to engage in this experience from 29 of those who strongly agree to 48%, and then those ones who had an intent to actually visit from 48% to 61%. And those are some of the quotes we got from Nairobi and Migori around inspiration, around the idea of an alternative. And these are some of the insights we are taking into consideration, even as we think about what WASI 2.0 can look like, what the next phase can look like. Last slide. Last slide. So we had a couple of lessons like that. There are quite many, but we were able to shift drivers in an implementation period of 4 months. We're very excited about that. And as even now that we have a product that's ready, we're very happy to see what else can go into it in terms of more concierge partners, because we got girls having more needs than we could actually meet within the 3 partners that we identified. And then chatbot in itself having that interaction. It was very user-friendly, coming out with some of the insights. right? And then without leaving the platform, you could get all the information and even actually talk to a hotline and somebody on the other side. We are calling that human in the loop. And then I think the only thing that we saw a limitation and also is around how much we could influence around attitudes and experiencing when accessing services, which would also point to how we've designed and the time span that we have right now. So as we go into phase 2, then we're very keen about some of the areas that can be better, especially in terms of a better consumer journey for the young women that we are designing for. Then the last slide is it. I promise. This is it, the last one. So this is Wazi. That's our USSD number for Kenya, and we are also on wazi.ke. Do reach out and engage with our platform as well for you and for the young people around you. Thank you so much.
All right. Thank you, Nancy. Please put your questions and comments in the chat. And I should have apologized before I introduced Nancy, but as timekeeper, I am really going to try to keep us to 8 minutes or 9 at the most per speaker. Without further ado, over to Prisa from Jacaranda. Welcome, Prisa.
Hi, and thank you. If we can have the slides up. Yeah, so my name is Priska from Jacaranda Health, which is a maternal and newborn health nonprofit organization based in Nairobi, and most recently just expanded to Ghana and Eswatini. So today I'll talk about our learnings from a USAID-funded project that looked at ways of improving uptake of postpartum family planning among Kenyan mothers through a mobile health approach. So next slide, please. So how does this mobile health approach look like from the Jacaranda context? So we do have an AI-enabled digital health service that we call PROMS that aims at helping new and expectant moms navigate the health system much better. So it's made up of 3 tools. So one is the sequence of gestation stage specific messages that empowers moms like Beth with information to seek care at the right time and the right place. 2, an AI-enabled clinical desk that reads and responses to incoming questions from moms and sparks a referral chain if a risk factor is identified. Number 3, it has a comprehensive data structure that routinely prompts moms to share feedback on their experiences of care. And this feedback is shared back to the hospitals and health management for them to be able to make more targeted improvements. Next slide. So in Kenya, the issue of short birth spacing is a real issue. So we know that half of pregnancies among Kenyan women occur before the WHO recommended 24-month birth to pregnancy interval. So in light of this challenge, we do recognize that the PROMS platform, which up to now has been able to reach approximately 2 million moms across Kenya, could potentially help shift behaviors around birth spacing via the SMSs that we send to moms. But to do this, we needed to first dig into what these contextual behavioral barriers are, and then adapt some of our tailored messaging on prompts to support improved uptake and adoption of postpartum family planning among the moms on our platform. Next slide. So we did conduct qualitative research in 2 areas in Kenya, so that is Kajiado and Nairobi. And these places were deliberately chosen because of their rural versus urban setting, of course, assuming the differences in awareness and adoption of family planning between the 2 county populations. We also assumed that decisions around family planning were not isolated to just the mother, but rather influenced by other members of the community as well. So we incorporated feedback from voices of the male partners, traditional birth attendants, community leaders, healthcare workers in this research, so that we are able to understand what the actual influences in terms of uptake to family planning is. Next slide. So when we sat down with the group of women and their support members from the community, we quickly realized that understanding the acceptance of family planning was a pretty complex issue. So one of the most common threads that came out of the discussion was many misconceptions that women and their communities had around family planning and the various cultural beliefs that prevented their uptake. Of course, religious beliefs also came up quite a bit. And then next slide. So interesting. Well, certain care structures inhibited uptake to family planning. So for example, mother-in-laws were talked about as having a real influence over decisions around uptake. They were also supportive. So for example, we also had cases where it was useful for us to know that childcare was seen as a shared responsibility amongst women and their communities in Kajiado. And many respondents also talked about how childbirth and family planning was the issue of women rather than something that a male partner might involve themselves in. So this was interesting to us because we recognize that we have this opportunity to engage and educate the male partners, because currently our prompts platform has approximately 10% of our users are male. And we can use the platform to share PPFP messaging specific to them and their role in it. And lastly, like information gaps around postpartum family planning also emerged as a major theme in discussions, which really re-emphasized our motive for sending out free, clinically accurate postpartum family planning messages to our user base on our prompts platform. So based on this research insights, so we sat down with a couple of the people that were involved in the initial research and developed a really simple message flow to go out on prompts, where we asked users to tell us what information they wanted to know around things like family planning methods. So however, our first approach, the engagement, you moved on to the next slide, sorry. So the engagement was a little bit low. And we came to realize that because of knowledge gaps around family planning, identified in the research stage, women did not really know what to ask about if you leave it open-ended. So we did do a different test where we did a counseling approach. So in this approach, as you can see, moms were counseled through a series of questions that asked them about their preferences as a starting point before being offered a suggestion of what method would best fit their preferences. And in this scenario, we saw a higher engagement rate compared to the previous one. And that became like one of our focus ways of creating the content for the PPFP messages. Next slide. So what can we learn from all this? So a couple of things. So one, format of the messages. So through the prototype messages, we found engagement rates significantly increased in flows where mothers were given response options. So in terms of timing, safety, family planning methods, open-ended options So cases where users were not prompted for any options, the engagement was really low. So number two, timing of sending out messages. So we found out that it's important to send messages both before delivery and after delivery, just to enhance preparedness of the mom in terms of deciding when to pick up a family planning method and also which method to select. And when it comes to family planning method preferences, so we had moms asking a lot of questions around questions around when it's safe to resume sex. And when it comes to the family planning methods, there was a lot of questions around how to actually select a method that best fits their preferences. And one important thing to also mention, I know we haven't really talked a lot about male partnership involvement in the research that we do, but we did send out a couple of messages to fathers as well to test uptake and interest. And it was surprising to see like a strong engagement from them as well. And some of the questions we saw were similar to women, questions about when it's safe to resume sex. And when it comes to family planning methods, the male partners asked a lot of questions around the rhythm method. So while these insights are really helpful in helping us determine how our PPFP messages on our prompts platform will adapt to best fit the needs of our moms, we are also going to be digging further into the impact of these messages on PPFP uptake through an RCT that we are currently conducting over the next couple of months. And we will be super happy to share these results at the end of the year when they'll be out. Thank you.
Wonderful. Thank you so much, Priska. And I found that super interesting because I know also within the broader business model of Jacaranda, it involves maternity hospitals, right? So there's really important linkage of where people go to have their maternity care and deliver their babies and then consider postpartum family planning. So thank you. Next up, we have Tiko and Sarah, the Chief Impact Officer. So over to you, Sarah, and welcome.
Thank you so much. Shall we go to the next slide? I will be speaking to all of us today about using innovative financing instruments to expand access to both sexual reproductive health and rights, as well as HIV interventions among adolescents and young people in Kenya. Yeah, let's move on to the next slide. Yeah. A little bit about Tiko Africa. We were formerly known as Triggerize. We rebranded in December. We're basically a global nonprofit organization headquartered in South Africa. We primarily work with adolescents and young people around making positive choices by using innovative technology and real-time data, as well as behavioral insights. At Tiko, we use what we take a platform approach that ensures that we connect both the demand side partners to the supply side to enable the adolescents and young people to access sexual reproductive health products and services. So when we talk about a platform-based approach for ourselves, we use the Tiko platform, which is an application that's usually facing the providers, and the providers here would mean community-based organizations, community mobilizers who create demand for services and products, as well as community health promoters when we think about mobilization for the public sector. And then on the other hand, then after the young person gets enrolled onto the Tiko platform, with the Tiko membership, they'll be able to access services at both private and public facilities. And private facilities here refer to both private clinics as well as pharmacies. And so with the Tiko membership, a young person is able to access services through the private sector that are fully subsidized by us using funding from donors. Next slide. So today I'm going to center my conversation around development impact bond that we are using to implement our work in Kenya, and basically try to showcase the role of private sector also in investing in sexual reproductive health services. And for Kenya in specific and the development impact bond that we'll be talking about, we have a private sector investor known as the Bridges Outcome Partnership that has front-loaded upfront funding to Triggerize or Tiko to be able to implement through a Pay for Success program, basically. And once these outcomes are achieved through impacts that have been defined, then this investor known as Bridges is going to be able to receive a refund or funding from the UN, the Joint SDG Fund, as well as the Children Investment Fund Foundation, who are the outcome funders. So this is really an instrument that goes beyond the traditional grant mechanism, and it is aimed at addressing the whole lack of access to quality sexual reproductive health services, and then work towards ensuring that, more than 300,000 adolescent girls and young women in Kenya will be able to access sexual reproductive health products and services, as well as HIV services through this fund. So I will not be just speaking about using innovative financing for SRH access, but also looking at the place of integrated service delivery in a context such as Kenya, where sometimes there's pushback around why would an entity be providing contraceptive services to adolescents and young women aged 15 to 19-year-olds. So the entry point of HIV is important for us because the particular circumstances that preclude a new HIV infection or an unplanned pregnancy for a teen person are almost similar. So we're addressing cross-sectionalities with this instrument. And the interest about the different funders coming together is that on one hand, for instance, you will see the likes of UNFPA and the Children Investment Fund Foundation interested in the outcomes related to contraceptive use, while an entity such as the UNAIDS is interested in the outcomes related to HIV prevention, care, and treatment. So in overall, we are doing this work in Kenya. We started in June of 2023. It's a 24-month program, and the beneficiaries are 15 to 19-year-olds in 10 targeted counties. Next slide. So these are the 5 payment metrics, if you may, outcomes that we must achieve as the service delivery partner in order for the private sector investor, the Bridges Outcome Partnership, to be able to be paid by the Children Investment Fund Foundation, as well as the Joint SDG Fund. So we're looking at family planning services provided through the Tiko platform, HIV services provided and received through the platform as well, and then looking at continuation metrics around short-term methods, as well as HIV repeat use, which will basically be speaking about individuals or young people who need to retest, that they are able to do that, young people who need to be on PrEP, start on it and continue on it, and young people who are placed on antiretroviral therapy, start and continue. The other interesting metric is that given that this is a fully subsidized model when it comes to private sector access, it is important that we continue to demonstrate that we are actually reaching the vulnerable girls who outside of this mechanism would not be able to afford access through the private sector. As Tiko, I also want to reiterate that we are heavy on choice, giving the young person choice on the type of facility that they would want to access these services from, including when and how they would want to access the services. So one of the critical metrics that we must demonstrate is that we need to demonstrate continuous reach to and support girls and adolescents who live in multidimensional poverty geographies or households that we demonstrate that we are increasingly reaching those type of girls and that they are taking on services. So these are the payment metrics that we have under the development impact bond. And these are the outcomes, if you may, that the funders are paying for. And you can see our performance to date. And I will go a little bit in the following slides about the performance as well. Next slide. So when we think about the girls that got enrolled onto Tiko, these are the numbers that we are looking at. Approximately above 160,000 girls were enrolled onto the Tiko platform between July and December of last year. And I want to say that girls and adolescents primarily get enrolled onto the platform in three major ways. If they don't have a phone, they will get a card, and the community mobilizer or community health promoter will be able to enroll them onto Tiko. If the girl has a phone, if it's a feature phone, they may be able to enroll via SMS. And if they have a smartphone, they may be able to enroll via a smartphone. At the same time, beyond the mobilizer, a young person can do self-enrollment if they have a phone. And a young person who has a phone can also encourage and support another peer to enroll onto the Tiko platform, thereby becoming a member. And by becoming a member, then they have access to this profile of service providers that I will mention in a little bit. Next slide. So in terms of contraceptive services that we've been able to provide for the same period of time, we are looking at slightly above 166,000 contraceptive services that have been accessed by over 100,000 girls. Majority of them, or almost half, access short-term acting methods, and the other ones access the long-term acting methods. It looks like the implant is the most preferred family planning service by adolescent girls, and we can see the uptake was at about 58,000. The uptake was at about 58,000 in the period that I've said. And all these services are being provided at a total of 244 facilities in these 10 counties, 59 of them being public sector, 141 being private facilities, and 43 physical pharmacies, as well as one online pharmacy. Next. So as I mentioned before, that a good entry point for us with the development impact bond into increasing uptake for family planning services was the HIV service delivery. So and this development impact bond is two-pronged. So we're addressing both the threat around HIV infection and then also addressing the need for contraceptives among this target group. So for the same period of time, a total of 68,000 girls accessed the HIV services. And then you can see that a total of 71,000 services were accessed, meaning that there are some girls who definitely came in for more than one HIV service, whether that was a HIV test and then accompanied by a pre-exposure prophylaxis uptake or an ART uptake. Again, when it comes to the question of HIV services for the period, because we were still onboarding the public sector facilities, a majority, really 99% of the HIV services were obtained through the private sector partners. We have a total of 229 facilities that are offering HIV services. And for this period of time, 55 public sector, 129 private clinics, and 44 physical pharmacies and one online pharmacies were able to provide the HIV services. Next slide. So I will just conclude by talking about, why a development impact bond, is a good tool to scale access among this target population. One, with the development impact bond, we are forced really to think about innovative ways of delivering the impact, because what the funders are ultimately interested in is the outcomes that we have committed to. And it is quite tight because you have specific timelines, and it's a pay for success, it's a strictly pay for success kind of program rather than your normal grant where you could be, implementing, potentially not meeting your targets, but the funding still continues to be sunk in. So by having a different investor, a private sector investor come in, you know, the funders are able to transfer the risk of delivery to this entity, which then is the one that funded Tiko to be able to implement this work. Also, the laser focus around the impact just ensures that, you know, by design, we need to innovate. You know, we are tight on how the operations are set up so that we are able to deliver these outcomes. And with that, there's also a very comprehensive impact measurement and reporting framework in place, including a full verification mechanism that really tries to understand that, you know, real girls were served at real facilities and there's really value for money. A development impact bond definitely brings new financing mechanism into the sector, allowing donors and service providers to focus on the social impact maximization. Thank you very much.
Sarah, thank you so much. Absolutely fascinating. And I know that some questions started to come in the chat. I know that Magua from one of my colleagues mentioned one question I have. And so please take a look at that and we'll have more time for discussion. With that, we'll go next to PS Kenya and welcome Sylvia. Over to you, Sylvia.
Good evening. Good morning to you all. Happy to be here today. I'm going to take you through what the USAID Private Sector Engagement Program is doing here in Kenya. This is a health system strengthening mechanism that is being implemented by 3 partners. Population Services Kenya, where I work as the COP, is the lead organization. Then we have Halcyon Consulting and Kenya Healthcare Federation. Next slide. The main purpose of this program is to improve health outcomes through increased patient choice of quality health products and services in the private sector. We know that the private sector is very critical in Kenya. 50% of the population access services from the private sector as a first stop. And in addition, we have about 15,000 health facilities. 50% of them are privately owned. Either they're full commercial or they're run by FBOs or a few by NGOs. Our vision is very bold. We want to have a transformed health market delivered through country-led and country-owned partnerships that increase and optimize private sector resources to expand health options equitably and in a sustainable manner for the benefit of the Kenyan population. We'll be focusing on 3 main things. Maybe I should have mentioned that this is not an old program. We are about 2 quarters old, so I'll still be talking about what we intend to do more than what we have done. So we'll be focusing on increasing the number and types of services being provided through the private sector. As we've said, this is very critical. And if we have to lessen the burden that the public sector has today, then we have to be adequately offering the services. The other thing is that we'll be working on improving the quality, a component of that, so that the products and the services being offered through the private sector meet the quality standards. And the third one is to strengthen local manufacturing. We'll be doing this in conjunction or through supporting the Ministry of Health and many other stakeholders that are in that space. Next slide. So this program is focusing on 5 main health areas: HIV, family planning, TB, malaria, and MNCH. But for today's purpose, I'll just focus on family planning. Next slide. So what will we be supporting? The first thing is capacity building. We know that the government can never have enough resources to build the capacity of the public and the private sector. And that's why we are coming in, recognizing the importance of the private sector to ensure that the quality standards are being met. And of course, you know, capacity building becomes extremely critical. So we will do this by working very, very closely with the Ministry of Health. And we'll use the MOH trainers of trainers to build the capacity of the healthcare providers in the various components, such as FP standards. We have an FP quality improvement standard, assessment tool that healthcare providers can use on a continuous basis to just check how they are doing in terms of quality. We'll also focus on Cyanopress, the provision of Cyanopress, and just letting the private sector understand the guidelines for the different FP methods, counseling for continuation, and also business skills. It is important to mention here that when it comes to business skills, we'll also be partnering with other organizations, such as Frontier Health Markets Engage. We'll be fronting to them the private health facilities. They'll be training them, And then at the end of the day, we'll be hoping that they will be bankable, because we know access to financing is very critical for the private sector. If they have to increase the number and types of services that they're offering today, then they need financing. We also deliver capacity building through utilizing professional associations. I mentioned at the beginning that one of our partners is Kenya Healthcare Federation. The Kenya Healthcare Federation is the one that brings the private sector together. So we will be delivering some of these courses, some of these trainings through webinars, through just mobilizing the private sector into one room and delivering what we feel that is critical for them. We'll also utilize the health provider networks, and where necessary, we'll do CMEs and also utilize online platforms. So you'll see mostly we'll be bringing the private sector together and identify the best channel that we can use to deliver the course or the training that they need. The other big component is FP commodity security. We are all aware that by 2026, the Ministry of Health will be, or rather the Kenya government will be expected to fund for commodities fully without donor support. So what does that mean? Today, when you look at the long-term methods, most of them are provided from the public sector. So that will not continue happening. So it's very important for us to think about a model whereby the private sector can start accessing commodities from manufacturers and even through the normal trade channels. So we'll start off by linking the private sector health facilities, pharmacies to suppliers, distributors from manufacturers for what is already in the market. And for what is not in the market, we want to see, can we start catalyzing some sort of the market by talking to manufacturers, coming up with a model whereby they can start supplying the private sector directly. This, of course, will need to be well thought, because today they're not paying anything. And I know some of the costs for those commodities are very high. So what models can we come up with? We'll also be supporting the total market approach initiatives. The total market approach strategy was launched in 2022, and the task force was put up or established by the Director General. So far, where we have reached, because this program is part of the task force, we are testing the data collection tool. The implementation framework was drawn. So now we are testing the data collection tool. And after that, we are going to do a pilot in one of the counties that has a heavy presence of the private sector like Mombasa. We are going to learn lessons and then incorporate the lessons and scale up. So it is still in progress. And this becomes very critical for this program because the private sector then plays its key role here. And we will also be supporting demand creation for family planning services in the private sector through social media and also through partnership with the Directorate of Health Promotion Unit, whereby they have a platform for sending messages or communicating to the general public. The other key component is health insurance for family planning. What are we doing here? I'll focus on the private payers because I know in the last session, we talked a lot about the social health insurance fund and its implication on the private sector. So for the private payers, what we are doing, and this is under the leadership of the National Council for Population and Development, and also with funding from UNFPA, the committee came up with a business case, which was validated. After that, it was presented, policy briefs were developed, and then the policy briefs were presented to decision makers in the insurance company. So the next step is to just now have the insurance company cover FP in their schemes. This is work in progress. What we plan to do as PSC, the USAID PSC program, is just ensure that that implementation is smooth. There's a lot that will need to be done. Next slide, please. So the other last two components, quality improvement. And here we are working very, very closely with the Department of Quality Standards. Right now, Kenya is developing the Quality of Care Bill, which will be the authority or the board that will be assessing private health facilities for them to be empaneled for SHIP, the Social Health Insurance Fund. So we need to be part of that discussion so that we can drive the private sector agenda. We will also be working with the department to ensure that the private sector is utilizing the Kenya quality model for health. And a big thing is that we're going to come up with mark of quality for healthcare providers, almost like having stars. Like these facilities are star 1, star 2, star 3 as they progress. What this will do is to create a culture of self-improvement. Because at the end of the day, you don't want the clients to be seeing you have a star 1. They'll just keep you and go to another health facility. And in conjunction with that, we'll work very closely with the counties to come with quality awards for the facilities that have good scores under the FP standards and also QMH. And of course, for sustainability, we want the counties to take up the FP standards and be part of the normal supportive supervision visit. The second last thing, is our engagement with national government, both at our engagement with government, both at national and county level. The key thing here is that we are looking at establishing a health market TWG. Establishing a health market TWG. Can you still hear me?
Yes, we can, Sylvia, you're good. Yep.
Because I lost the presentation.
Oh, yep.
Yeah, so we are looking at establishing a health market TWG at the national level and county level. And this will be a TWG that will have very many stakeholders. It will have the commercial sector, manufacturers, treasury, poisons and pharmacy and poisons board, different departments of the ministry to just look at the Kenya market, not like the way the family planning TMA is looking at things, but now more holistically, because we'll be talking about the Kenya health market. How can we shape the market? How can we start, improving the market as a government and the private sector? And most importantly, strengthening the public-private collaborations at the county level. The other thing is data. I've lost the presentation. I'm not seeing anything. It's data. And because if you have to improve the private sector, then we have to use data for decision making. So what will we be doing? We'll be working very closely with technology companies to gather data, to just ask ourselves what products are available in the private sector. Where are they coming from? Where are they buying them from? At what price? And how much are they reselling the products at? So what are the gaps? What is the consumption rate? That is really going to inform the whole chain, and especially at the manufacturing level. So that is what we are doing as a program. And in addition to that, we are obviously looking at the private sector representation in all these acts that the Kenya government has formed today. But that one, I know it was discussed exhaustively in the last meeting. Thank you.
Wonderful. Sylvia, thank you so much. And I know people have some questions for you that we'll come back to during the discussion. Our final speaker is from MS Kenya. Pius, over to you. Welcome. And I think you might be on mute still. Are you able to unmute?
Sorry for that. Are you able to hear me now?
We are. Thank you.
Yeah, so good afternoon, good evening, good morning, everyone. My pleasure to be here. I'll be taking you through what we are doing as Maristops Kenya in terms of our private sector engagement. So we can move on to the next slide, please. Yeah, so I know this one has been mentioned by some of the previous presenters in terms of the private health sector context within the country. And just to mention briefly, yes, it's true, like Kenya's got one of the most elaborate private sector networks, whereby the private facilities account for 50% of the health facilities available within the country. And as you can see from the charts that are there, approximately 40% of the FP services are provided by the private sector. It's also worth mentioning that it has been shown that the private sector provides the first point of contact for anyone seeking services within the country, be it the private health facilities, the drugstores or the pharmacies. Most of the Kenyans seeking health services generally get to these facilities as their first point of contact. To just give a brief background, a synopsis of MSK experience in private sector engagement, we have been working with the private facilities for the past almost 15 years through our social franchise program, where we were working at some point with close to 400 facilities, supporting them in cross-cutting areas like health financing, business advisory, and quality. And we really saw tremendous growth in terms of service provision, whereby these facilities were serving an average of above 300,000 clients a year. And we were able to scale up access to quality and client-centered SRH services through these initiatives. We were also over time and through our support, we saw that a number of facilities were able to transition or grow from small-sized facilities to the level of referral facilities, what we call nursing homes locally. The number of facilities that were accredited by the National Health Insurance Fund were also able to grow tremendously. So over time, we've reviewed our network, and our focus was shifting more towards sustainability. And we were able to cut down our network from the then 400, close to 400 facilities to 100 facilities that we are working with. That we are working with currently. And through this, we are able to just demonstrate a proof of concept for a scalable private sector network. It's also worth mentioning that as we were scaling down, we were also keen towards delivering services to some of the priority population groups that otherwise would not have sought services from our normal private sector facilities. And through partnerships with our local partners like Triggerise, we've been able to grow our reach in terms of the adolescent clients, where for the past few years, we've seen a tremendous growth in terms of the proportion of adolescents served from about 15% to 49%. Next slide, please. Yeah, so as we were progressing with our social franchise engagement with these providers, we also undertook a landscaping analysis so that we can understand what are the underlying market constraints that prevent full access to contraceptive or generally SRH services within the Kenyan context. Our support to these facilities has evolved, rather it's evolving from providing core demand and supply, kind of support to playing a more facilitative role that is geared towards and addressing the underlying market constraints. And this one has been proven to be quite beneficial to governments, to providers, and to clients, as detailed there. Next slide, please. So from the analysis of the market and looking at the different constraints that are there that inhibit or that prevent full access to SRH services, we were able to come up with these 5 constraints. And these are the ones that as an organization we're moving forward to address so as to guarantee full access to SRH services. I'll be providing a bit of details on each of them in my next 2 slides. So next slide, please. Yeah, so the first constraint that we were able to identify was inadequate family planning commodity security. And I know some of the presenters that have gone before me have alluded or rather shed some light on this, but it's also good mentioning that, yes, the resource envelope that's available for the purchase of FP commodities has been decreasing over time. It's also known that back in 2019, the national government signed some MOUs with funders and donors through the MOU, there was an expectation that by the financial year 2025-2026, the government was going to fully fund its contraceptive needs. But something interesting to mention is that the allocation for family planning has been oscillating somewhere between 45 to 50% of what was committed. And it was actually a very ambitious plan because going by the allocation as at then it meant that the government had to contribute its allocation for family planning. But going by the trend that I've mentioned, then it's quite unlikely that the government will deliver this commitment. The last few years, I've seen the government moving forward to ring-fence the commodities available through the public sector, and this leaves the private facilities with no other access to these commodities. So just to mention, MSK alongside other like-minded partners, we are working towards creating a viable and dedicated supply chain mechanism for the private sector so that they can access these commodities and continue providing services to our clients. The other constraint that we identified was around visibility of private sector data. And of course, when this data from the private facilities does not make its way to the government MI systems, then it leads to some suboptimal decision making, and we cannot fully quantify the impact that is delivered through the private facilities. It is also worth mentioning that last year the government signed the Digital Health Act, or rather bill into law. And this is geared towards creating a digital superhighway that's going to see seamless sharing of data and decision-making based on real-time data. So in this particular area, we are working with the different facilities that we have within our network to just ensure that we support them through the counties and sub-county management teams so that they can get, or they can be registered and issued with what we call master facility list code, through which they can report to the government KHIS. In terms of limited enforcement and regulation of quality, yes, within the public discourses, we know very well that the quality of services within the private sector has been highly contested. And of course, the government stewardship function is not able to really provide oversight within the private facilities. In fact, most of them don't even get visited once they get the initial license to operate. And with that, the quality provided within these private sector facilities has been, in most cases, described to be poor, with most of them deemed to operate inappropriately and opportunistically. So we have been providing quality support within these facilities, but for the purposes of integration and sustainability, it's worth noting that the government has got a public quality assurance framework we call Kenya Quality Model of Health. And yes, we've started some initiatives of working with the different counties to just see to it that the public quality assurance framework also extends to the private facilities, and that the different counties, because health is involved, are able to, rather they should have visibility of the quality within these private facilities, and we provide that necessary support so that the private facilities quality also improves. Next slide, please. Yeah, so the last two constraints that we were able to identify, one related to lack of demand for family planning and SRH services, of course, due to misinformation and disinformation. Yes, this has been a key inhibitor, especially within the rural areas. We know we live in a largely patriarchal society where even the messaging, the message that most of the decision makers within these communities have is not correct, and they are not able to really support the partners' decision to seek SRH services. So with, of course, support from MSI, we are working with government, SBCC, and other CSO partners to revamp SRH messaging. And we're also working towards challenging some of the harmful social and gender norms that hinder access to SRH services. We also, of course, leveraging the different capabilities that we have in terms of digital and manual tools, so as to pass the message. We have an application we call Community Connect that is able to it's able to really guide our different community-based mobilizers and provide some of the information through a digital library on how they go about crafting and sharing the different messages around SRH services. And lastly, the last constraint that we were able to map was financial support for family planning. Yeah, so with this, I know previously we have supported our facilities to make sure that they get empaneled by the National Health Insurance Fund. The government is very intentional towards ensuring that by the year 2030, we attain the universal health coverage. So by extension, this means that anyone will not be accredited by the National Health Insurance, then they will not be really operating meaningful business within this space, and therefore we've been supporting these facilities to ensure that they get accredited. There's been a lot of transformation and for acts of parliament that were developed last year, including revamping the National Health Insurance to Social Health Authority. Yes, we are keen to making sure that we support this facility to get a panel. And of course, just like some colleagues have mentioned, there is a total market approach task force. So through the same, we are also advocating to see whether family planning can also be included within the national insurance benefit package, so that our clients can get these services without suffering any financial hardships. Thank you very much. I beg to stop there.
Wonderful. Thank you so much. It's great to hear what Mary Stopes Kenya is doing relative specifically to market constraints. So that concludes our set of formal presenters. And just as I prepare to pass it over to Judy to lead discussion, also want to invite people if there are other current activities in Kenya specific to family planning and private sector or market development that you'd like to speak to very briefly, like a minute or so, please raise your hand, and we can also watch for that during the discussion. So yeah, so with that, Judy, over to you, and I can help watch to see if anybody wants to come off mute and share anything else. Oh, Judy, I think you're still on mute.
I haven't turned on my microphone. Thank you, Andrea. Thank you so much to our presenters and speakers today. We really appreciate the work you have put in preparing your presentations and delivering them. We'll kick off with a number. I've seen there's already a lot of engagement in the chat. I will pick up the questions that for which we haven't seen a response for yet. There are, from the presentation that I covered, which was verbal, was a summary of our last session, and we will link the slides from that session onto this one and share that out with the newsletter that goes out as well. Our initial questions will go to Girl Effect. Do we have data on contraceptive uptake after referral, after receiving a referral? And the other question is, how many similar interventions were in play that could have contributed to some of the numbers that you're seeing in your work as well? So that question goes to Nancy. As I give Nancy, if you're ready to respond, please go ahead, or I could also frame a few questions for some of the other presenters as well.
Judy, do I go ahead?
Go ahead. Go ahead, Nancy.
Okay.
Yes, please.
No worries, I can. Thank you for your question. Yeah, so on the issue of conversion, so we had around 12,700 girls messaging like a Jacaranda Health agent, and we had around 10% of these taking up services. So and then we're unpacking what that looks like down the funnel. So to just see out of the 10%, how many are we talking about in terms of contraceptives? So that's work in progress. Yeah. And then the other question around other players, yeah, that's correct. There is that attribution factor that we are looking at, but then we're coming in from an angle of contribution and this ecosystem that has more than one player and contributing to this overall health issue. And so that said, for our work specifically, we're following girls who are in our chatbot, like from end to end. From awareness, you've engaged with our work, you're taking up a service, and you're going all the way to see if you can take up a service towards the end, as represented in our funnel. But we are very cognizant that the other players who also work in the counties that we are in, who are also represented in this meeting, and we are happy to work together, as we have already started doing in our concierge role as part of the digital ecosystem.
Thank you so much for those responses, Nancy. The next questions are for Sarah from Tiko. I think there's a lot of interest in some of your work there, and nice to hear that most of the girls who have been reached prefer implants. How would you be able to share the strategy deployed to support uptake of this particular method? Is it because of demand created through the Tiko platform, or overall work by a number of partners to provide access to this particular method? And then the other question for Sarah, did you see a significant difference in uptake of methods between the private, when you compare the private and the public sector? And how would you explain that? Over to you, Sarah.
Okay, thank you for those questions. Quite thought-provoking for me. As a Chief Impact Officer at Tiko, these are the questions that keep me awake. So the question around the uptake of implants. So basically what we see from our current data, which is 6 months in or 7 months in after the start of the dip, is that we have seen a tremendous uptake in implants, especially in the public sector. And the type of public sector that we see, you could say are in what we might classify as a little bit of peri-urban or rural areas. That's where we are seeing an uptake in the implants. Part of it, from where I sit, has to do with how we have created the ecosystem of partners. We see a lot of tilted, method mixes when we talk about the types of contraceptives that people are able to access when we mix in different health systems. For instance, in countries, and I'm sorry, I'm not talking about Kenya here in particular, in countries where sometimes we have a fully private sector model that's sometimes heavy either on the pharmacy, we see a lot of uptake around oral contraceptives. So what we have continued to do, which sticks true to our mantra, is around, providing a different profile of service delivery points, because depending on what you provide within an ecosystem, then you could definitely see different types of uptake, which is attributed sometimes to the type of provider that you have in the facility and the type of training that they have, whether or not they're able to counsel for those methods or not. And then it is also a factor of the supply that is available. So we continue to push for, this mixed health system that actually provides choice for these girls. And then also really focusing on the counseling for choice aspects. Most of the times we see data around our monthly client exit interviews, giving us pointers around the quality of counseling and whether or not the young person has choice. And we use that kind of data to be able to inform not only our demand generation, but also support the providers to be able to assure and ensure choice for the young people. So I think in a nutshell, Judy, I hope that I have answered both of the questions that were presented, because they were quite correlated. Yeah.
Absolutely. Thank you so much, Sarah. And I think over the next questions would be for Sylvia. We have quite a few. And I think a combination, some between Sylvia and Pius's presentation as well. Sylvia, how do you envision private payers how do you envision the inclusion of family planning into private payer coverage? And with the enactment of the Social Health Insurance Fund, would that negatively impact private health insurance sector in terms of membership? Because this is a mandatory requirement for enrollment. So how do you envision the impact on private health insurance and the impact on private health insurance and coverage for family planning?
Thank you very much, Judy. So how we envision the private payers covering for FP, what came out because we engaged with the private payers, their main problem is show us the business and we're ready to cover FP. And of course, based on the business case that was provided, they saw that there's room for them to do that. Today, they're covering for FP, but mainly through corporate clients and when it is included in the tender. But most of them have been covering it as part of the larger package, so that you have a cap for all the items that they have covered, and you can also take up FP. So there are all those models. The different insurance companies, there are some that have a cap for what women can use in family planning. The cap is not so much. It might not be adequate, but those are the conversations that we're continuing to have with the private payers. So it is possible, it is already happening, but not to a large extent. So in terms of how SHI is affecting private payers, that is a big discussion. In actual fact, we plan to have a round table between the private payers, the private health insurance, and someone to just unpack for them the Social Health Insurance Fund and their space. This is not going to affect everything because not all the people can go to the public sector. Not all of the people can go to a facility whereby a certain amount, a certain product is only covered up to a certain point. So we'll be unpacking that and showing them that the social insurance fund does not take up everything that they can possibly, and this applies to everything else, Judy, not only for family planning.
Indeed, Sylvia. And I think emergent news is that the private insurers will also be processing claims from the social health insurance. So I believe there's already work in there into integrating private health insurance within the social health insurance fund as well. You have a question for you, Sylvia. Again, is the private sector represented in family planning quantification meetings? And another question for you, is there, are there any manufacturers of family planning commodities in Kenya? Over.
Yes, Judy, the private sector is represented in the quantification. We are also represented, and even previously the organizations that have social marketed products have also been represented. So that is taken care of. Even the task force has a wide range of representation. So in terms of local manufacturing of family planning products, recently we saw, that was towards the end of last year, there's a factory that is being set up in Mombasa for manufacturing condoms. But for the other FP methods, we have not heard of any.
Thank you for your responses, Sylvia. Question over to Pius. Thanks for discussing some of the sustainability and scalability aspects of the MSI network. With the current reforms in social health insurance, have you identified any barriers for the private sector to get empaneled?
Thanks for that question. Allow me to say that we are actually at the early stages because you all understand that there were quite a number of cases challenging the transition towards social health insurance. But we, of course, have done some groundwork, and we understand that the government will be very keen on the quality of services within these facilities. So the biggest barrier that we've learned from experience has always been quality within the private facilities. And that's where we are coming in as a franchisor, though we are moving away from providing that franchise support, but we are coming in now to support these facilities, working in collaboration with the different county and sub-county quality leads to ensure that we support these facilities in quality and they get seamless empanelment once everything is set on motion. Thank you.
Thank you for that. I think maybe the last question will go to you. Will go to you, Pius, and also maybe a contribution from Sylvia as well. I think it is Lucy from Zambia who would like to understand how you have managed to work to have family planning covered under private sector insurance. I think overall both public and private sector insurance. So if you'd be able to share just a quick overview, that will close our question and answer session for today.
Thanks for that, Judy. So within the private sector, I think, and I think someone had alluded to that, it depends on the policy that you have with your insurer. So yes, for some, they've been able to provide that particular coverage. For others, it has not been there. But within the national health insurance, it hasn't been there for the general cover, except for some enhanced civil service coverage. Yes, different partners within this space are working towards advocating for expanded benefit package that could include family planning. But as of now, it is not expressly covered within the national health insurance. Maybe Sylvia could also provide some details from their end.
Yes, so just to add, in regard to social health insurance or NHF, they were covering it under Linda Mama, but just for postpartum. And so that was not very inclusive. But right now, I know there's a lot of advocacy being done to ensure that FP is explicitly covered in the Social Health Insurance Fund. So it is still work in progress.
Thank you for those responses. Thank you to our speakers for responding to our participants. I'll hand this session over back to Andrea for us to close.
Oh, thank you, Judy. And I want to emphasize also my thanks for everyone attending today and for this fantastic lineup. It strikes me that this really brings together the fact that some organizations are deep into one area, say maybe working on social behavior change and access, while other organizations are looking at the multitude of factors that really impact ultimately access, sustainability, choice in family planning, and also the integration with other health services such as HIV. Really, really interesting. And I think it also shows that it is about being a community, right? So that it's not one approach that will make a difference in the long run. We had originally set the time to run a little bit past 9:30, but it looks like in this case we're in a good place to wrap up. We'll just go to the next slide, Elizabeth, or maybe is there one before that just yeah. So what we just wanted to share again is this link to the survey that we mentioned earlier, and that link should work for you, and we'd really appreciate you providing input. It also asks questions about future topics that may not just be country specific, as well as countries, because FHM Engage as the Secretariat is really working to be inclusive, and we appreciate that. The next session is tentatively set for February 27th, as you can see on the screen, to focus on India. And I didn't see anyone else noting that there was anything they wanted to share today, but please do keep spreading the word. And if you have any issues with accessing the slides or the recording, please reach out to Elizabeth. And it looks like, thanks for those who are asking about the link. And Elizabeth, can you put the link to the survey in the chat, because maybe the link isn't working for people from trying to click on the slide. I'll also note that the survey link was put in the newsletter, which Elizabeth sent out, or the invitation to this call, it was sent out about a week ago. So that's there as well. And I think that's it, unless there's anyone else who wants to come off mute and make any comments. But again, from USAID and UNFPA, a big thanks to our FHM Engage colleagues who are putting this all together. And again, a huge thanks to the speakers. And I know I personally am going to do some follow-up conversations. And a final thanks to USAID Kenya. Jane, that was a great kickoff set of remarks and really set the stage for the private sector emphasis, which is what we're really working towards in this market development. So with that, please reach out if you have any difficulties accessing the survey, and we'll see you in about a month to talk about India. Thank you.